All right. I think we're going to get started with the afternoon session. It's my pleasure to introduce Godavarthi and Danny Cawood. They are going to talk about answers to prior authorization burden reduction, regulation versus automation. And I just wanted to thank MCG for long-term support of WEDI. Thanks to our other sponsors, EdFX, InterSystems, and the latest sponsoring organization, Doc Studio. I encourage you all to take advantage of having these experts and stop by their booth and talk to them and learn about their solution. So with that,
thanks, Rob. Thank you. So we're going to talk about the prior authorization from a different dimension than what probably you have heard today. We're going to look at the regulation side, what's been happening. Then we will look at what's happening on the automation side using technology and AI, how they both are competing and creating quite a bit of drama in the industry. So we want to bring a perspective so that you can see the problem is being solved from the multiple dimensions, but where payers and providers are stuck in between as well. So we'll talk about our experience part of the process. So with that, I will ask Danny, is our product manager. We'll take the first stab at the regulation.
Sounds good. Thank you, Raj. Okay, there we go. So I wanted to talk a little bit. Well, I'll introduce MCG briefly. Many of you in the room here are partners or customers of ours, so I won't spend too much time here. But we are formerly known as Milliman Care Guidelines. You may know us as Milliman Care Guidelines. We were acquired by Hearst Health in 2012. We are deeply embedded in this space. We have a majority of U.S. health plans use our criteria, our evidence-based medicine criteria, for the purposes of prior authorization. We also have about half of the United States hospitals using our criteria for medical necessity reviews. In the past few years, we've gotten into lots of different interoperability world, since we do have customers on the payer side as well as on the provider side. We do a lot of work here. Raj serves on the HITAC board. He is also a WEDI board member. We are members of the HL7 Da Vinci work group, and we are one of the first to market. You heard Kirk and Heidi speak this morning. We are one of the IT vendors who helped them implement that Da Vinci workflow that they did. When we talk about authorization burden, I won't spend too much time here either, but it is a labor-intensive process. Causes a lot of friction for payers, providers, and patients, most importantly, patients. They're very costly to do, depending on who you look at. They're anywhere from $20 an authorization for payers and providers all the way up to $75 an authorization for payers and providers, depending on the workflow. Very, very expensive. And there's a tremendous amount of opportunity here, and that's what we're going to talk a little bit about from an automation perspective. When we talk about recent regulations, we've had a lot of presentations today about the PARDD, the prior authorization requirements, documentation, and decision rule. I'm going to talk a lot about the requirements part of this, and we'll go through this whole thing. So the requirements from MCG's perspective, these are all the business rules. So query the payer system to determine if an authorization is required. The next piece is obviously our bread and butter, where the documentation requirements come in. So if an authorization is required, what are the documentation requirements? What are the clinical data that the payer is looking for in order to approve that? And then the last piece is decision. This is all of the sort of transactional rules about it. So do all the identifiers match for the patient? Do all the identifiers match for the authorization? Do all the dates match? Are all the approved units there? Once we've gone through this entire process, essentially, is the claim going to pay? Because if we go through this entire process and claims don't pay, it doesn't matter. We failed. Even if the authorization itself succeeded, we failed if the claims don't pay. I was talking to Brian. Brian had a great presentation earlier. He said, no one's talking about this documentation clinical rules piece, how implementing CQL, implementing some of that technology. No one's talking about how hard that is to do. I agree. I also think, and I said this to Brian, I also think no one's talked about this. The boring part of this is an authorization even required in the first place. So I know we've got a lot of payers and quite a few providers here. How many payers, let me actually start with the providers. How many providers in this room know what their Blue Cross Blue Shield specific ID number is, or any other payers that operate in their state? Not many. Maybe everybody's asleep after lunch, or maybe nobody knows. Payers in the room. If I give you a provider first name, last name, NPI, and tax ID, that's the only thing I can give you from the EHR. How many of you can return exactly one search result for that provider to tell me whether they're in network or not? I'm guessing not too many more of you than providers who know their payer-specific IDs. So those types of problems are all over here in these business rules. Is this code that's being ordered a covered benefit under that member's plan? Is that provider in network? Are they gold carded? Have they recently had their gold card revoked? Any types of those questions this is not as simple as, is a CPT code on the PA list or not? There are a lot of business questions that have to get answered before you can give an accurate answer as to whether a prior authorization is required. If you default this to yes, lots of problems in terms of authorization burden, having a bunch of requests coming in that providers didn't need to submit, and now the payer has to process. If you default to no, a lot of claims are not going to pay because a prior authorization ended up being required for one of 1,000 different edge cases that might exist. So agree with Brian from EdFX, documentation, yes, and also this business rules piece is something that we all as an industry need to get better at answering some of these questions about the business side of this in a more automated fashion so that we can move forward. Tons of regulations around prior authorization. So this is around reporting. These are the states that have active reporting laws around prior authorization metrics today. There's actually more than this, but these are the ones that are requiring you to put it publicly somewhere, available for public consumption. Most of these states have Medicaid related reporting rules that they require. Gold carding. The blue ones are enacted. California and New York have something on their docket right now. But these are some of the states that have done things around provider gold carding, and there will probably be more as we go. Tons of other areas of prior authorization. A few states themselves have gone down the electronic prior authorization route, mandating either the use of portals and a couple even mandating some interoperability pieces. Tons of regulations coming down. Raj is going to talk a little bit more about some of the other things going on from the federal level. There are also, if you can do this successfully, so that PARDD, all of those things, requirements, documentation, decision, from within the provider's EHR, not from your portal, but from within the provider's EHR, there are results that you can get if you can do that well. So these are some of the results that we've had. So when we talk about on the top left here, or on the top right, excuse me, left and right are a struggle today. Delayed flight, I got in at 1 a.m. But before we implemented this, 3 to 5 prior authorizations per user per hour is what this provider was doing. Afterwards, 12 to 15, a tremendous productivity increase. And I'll tell you why, and I'll tell you a little story about why before I turn this over to Raj. So we're 3 months into this. This was actually with the region's Blue Cross Blue Shield, the Cambia team that you saw present earlier. We're 3 months into this with one of the big providers in their network. That provider had told us at the beginning, this is our region's Blue Cross Blue Shield, is one of our biggest payers, and we'll submit everything through this for regions. We are 3 months in, and the Cambia team came to us, as well as our executive team came to us and said, there's only like 70 authorizations that have come through here in 3 months. And we were like, that seems really low. Why is it really low? So we went back to the provider. We said, you only sent in 70 authorizations? And they were like, no, we sent like almost 400. And have you ever like been speeding down the road in your car and like you go under the bridge and the cop pulls up behind you and you're like, I just got caught. And I looked at Raj and I was like, did we just lose like 300 authorizations? That would be bad. We didn't. 83% of what the provider was trying to submit didn't require an authorization in the first place. From the provider's perspective, they had submitted 300 and however many they had submitted almost 400 authorizations. And over 300 of them came back as no authorization required, and they got to stop really, really early in their workflow and not continue down the rest of the submission path. And they didn't have to chase down answers then for all those that they needed to get submitted. That's where this lift came from. So the clinical review itself being automated, Heidi showed a few screenshots of that this morning. That is definitely part of it. A lot of this lift came from those business rules of is an authorization required and getting a non-affirmative no, right? Like it's no, we don't need one. You can stop and carry on with whatever else you were trying to do. A lot of that came from there. Lots of other numbers up here, but this is some of the data and some of the hurdles that we can clear using some of these technology elements that we're talking about today. With that, Raj, you want to take it?
Thanks. I think the one point I'd like to mention here is that we have done the two use cases, one with Cambia on the prior auth side and the other with CareSource and Cleveland Clinic University Hospital on the inpatient side. Our journey started almost 4 years back, and this inpatient solution is in production for almost 2 years, and this is almost more than, I think, close to a year right now. As we are learning quite a bit about the real implementation of DaVinci and all the specs that we have read and wrote part of it, the other thing we realized in the last 6 months is quite a different challenge. I loved this when I saw the VDs. I think it is Sam's raining regs, right? We are seeing one every other day almost. There are a lot of things that are happening on the federal space that almost touches, like from the Cures Act, the patient access rule, the prior auth rule, the potentially the price transparency. They all have some connection to the prior auth implementation. So while we are being challenged by all these rules, the other thing that I have seen in the market, we're actively implementing these things in several places. But what we have counted is that there is an aspect of regulation that where we are telling this would work, but then there are a set of other technologies that are in the play saying, you don't need probably all these things, just use machine learning and AI that will solve a lot of the problems, right? People are really, putting doubts on like, this won't work. Providers will never give you the data. They're not going to implement it. It's not going to happen. Your best shot is artificial intelligence. And I don't know whether to believe it completely or not, but we are in the game right now to see, which one is true. Probably, end of the story, probably in 2 years from now, we will hear how they both will fare. But what we are seeing is healthcare is ripe for the AI automation, right? It happened to Amazon 15 years back. If you see last 2-3 years, healthcare is all over on the AI. So there are a lot of studies on this as well. And then people are saying that anything that requires human touch is up for grabs, right? So this created quite a bit of challenge when we go and talk to the EM folks on the payer side, that we are going to lose our jobs, right? But to some extent that it's already happening with the technologies that is being introduced, especially the ChatGPT that's creating the waves. And then McKinsey, I think it's I forgot the name. So they came with this report, McKinsey, that AI-enabled PI can automate 50 to 75% of the manual tasks. It's a very nice report if you haven't read this. It's free. You can just Google it and read it. So they published, I think it's last year, in a very nice, probably 2 or 3 pages. And they showed us, like, what are the areas that you can think about from the AI perspective. So the question is, as we are talking to several payers, the dilemma for them is that which one works better. And if there is no other slide, if you don't remember, this is the slide I would like to remember because it's going to hit you at some point. The group of people pushing regulations, like, I'm part of that as well, along with many. And there are technology companies pushing the AI solutions. So if you're a payer, if you're being hit by both of them, you're like, which one works better? which one has the fast ROI, right? And then if you're on the regulation side thinking that this is going to solve my provider aberration and burden reduction, all the administration cost, will the EMRs adopt the standards? How long? Cerner hasn't even started. Meditech, we haven't even talked to them. So Epic is doing good work, but a lot of other ambulatory EMRs. And then if you're on this boat, like if you're looking at AI solutions, and will this make providers happy? Probably some of the people are here, right? Some of the payers. So when we talk to the payers, we are getting bombarded by all these questions, right? Where do you play? We have other vendor who is doing some of the AI solutions. In the last at least 1 year, there are about 10 or 15 IT vendors, fully funded by a lot of venture firms investing in this space. They fully believe this is not the solution. This is the solution. We can get a faster ROI for the payer. And I see some of the payers are heading in that direction. So the reason I wanted to put this before you is that the longer it gets into the rule and make CMS, ONC enforce, these guys probably can win that battle because you're not getting the adoption at the provider level. So it's a real challenge for all of us, right? So I'm going to take the few slides just to give you the sense of what's happening on the automation side, what we are seeing, and what we are working on some other stuff. So you have an intake process, right? If you go to payer and say, I'm going to try to solve the FHIR problem, then they're asking, what about the other ones? I cannot just invest one path for, the full FHIR path and leave everything else on the other path, right? So you have this whole intake problem coming from different channels. Then you have the rule space, like you have some companies use some rules we call the business rules to automate the determination using codes, types of providers, types of services. Then you have machine learning companies, and to some extent we use DTR and codification to take the clinical data, and then we use a lot of technologies to determine the decision. So you have like the intake process, you have these rules based, then you have AI based. So if you put the prior auth workflow in these three categories, right, you can see where the data exchange using FHIR versus data, the solutions using AI playing in the space. So I'll show you some of these slides to explain a step-by-step approach. So if you're submitting the PA using different channels, the last one is Epic's payer platform. By the way, they have, they're grabbing a lot of market here because they have seen they can do a lot of that stuff unless ONC enforces them to release it for everybody. So if you have the PA submission coming from all these channels, the payers are asking that you need to have an intake automation process so that I can process all of them, not just the FHIR ones. So they're saying that you need to have a solution that can take an OCR if it is coming from fax or PDFs, convert into text, convert into one auth record. So the intake from all these should convert into one auth record so that they can run some rules, whether it is fax or PDF or FHIR or Epic's payer platform. So you have some technologies available today to do that. You can take a text and codify, and then you have recently ChatGPT offered this solution as well. You can literally take a 50 pages fax into a nice summary and make it part of the auth record, a digital auth record. You don't have to send the whole attachment. So if you think about the first two phases where you get the submission and then you process the intake, there's a lot of this work need to be done. If you just say that I will only do for FHIR, they're saying that that's not going to scale for me. You need to do it for all. So the payers that we have implemented, DaVinci, they're wrestling with this. They're looking at other solutions. So when I look at like what's the next 2 years would look like, that I see that we have to solve a lot of these problems along with DaVinci. So then the second part is once you have the digital record and you create a summary, then you can run these dynamic business rules based on line of business, specialty, vendor, where do you send this, whether it is Avocor, whether it is some other company. You have some people outsource that work. So unless you create this digital record based on all these things, you're not going to get here. Right? This is one step of automation people are looking at using technology. Then the next step is assuming that you got here. The McKinsey report says that you could automate almost 50% at this point without ever asking for documentation. We have seen with Cambia, they say 88% so far based on the things they're doing right now. And we are working with a lot of others and they're saying 50% is easy. We get a lot of them, doesn't require any prior auth. So what we're saying is if you create an AI engine that can learn from how you have made the decision so far in last 2-5 years, right? If there is data that you can put into this engine, right? It can learn the intake process, how you have made the decisions previously, and create an engine. Because right now we create a rules-based engine, it's really manual. It's not going to scale, right? You need to really have a mission to look at constantly how you are making decisions and create the new rules. So if you create a dynamic rule engine or something like that, then you can potentially automate a lot of the stuff here. I believe if you can do it at this level, you're going to get a lot of provider trust. The moment you ask for more documentation, you are losing them, right? So this is where Cambia is seeing the success, and we are working with other providers as well. You know, we work with CareSource in Ohio on inpatient side. They auto-approve about 9% to 16% of their auth requests. They're inpatient ones. It's a huge deal for Cleveland Clinic because they're not doing anything. If they click the button, they get an approval, right? So it is really important for us to do a lot of work here with the payer, to do as much as possible to give an answer to the provider initially. If you do 50% here, then you are moving to the other 50% to the next phase. At least that gives a provider to feel, okay, at least I'm getting a lot of success on some end, I have to work on the other end. So now we get to the policy. The opportunity they say is probably 30%, right? If you get all the technology work perfectly, you could still auto-approve some of them. Because you still have manual, like the other 20% somebody needs to look at. So here the opportunity is using technology. What MCG has done traditionally is that you take a policy, you codify it, saying that, if I can take all the policy, and as an example, if I'm measuring the oxygen saturation rate for a patient, how do you define oxygen saturation rate using coding standards, right? We created a language behind that. We call SQL, somehow expresses that, and it goes to a FHIR server and gets the data. So this is what we have done traditionally. But you're not going to scale this. We talked in the vendor group, some of our customers have like thousands of policies. They're not going to codify all of them. It's going to take millions of dollars to do that work and maintain them every year. The other option is do some NLP on top of it. But as I looked at ChatGPT, it could potentially take your policy, and if they release a specific version for the medicine field, it can potentially codify for you. So that is putting your codification on steroids, right? So now all of a sudden, your AI solution can not only codify your policy, but also it can interact. You can go to ChatGPT and say, can you generate a question on this particular book, set of questions from a book? You can generate a set of questions on your medical policy and have it interact with the data, right? So you can potentially scale this 30% of the reviews using technology to auto-determine, right? This is where a lot of people are investing. All of the AI companies I work with, this is where they're investing. ChatGPT is going to commoditize this. Like, you don't need to be really an AI expert, right? Most of the companies can do it in next 2 years. This is what we believe. So the opportunity here is that you're on this side of the spectrum, you're getting to the place where regardless of policy, regardless of what data requirements a payer has, what attachments they're looking for, you need a solution like this to scale it. Otherwise, you're still stuck at this place and this is still manual. And we are seeing a lot of this work happening right now. And then finally, the determination, right? Sending a notification letter is a regulation, right? ChatGPT can generate a nice summary. This is already in production in many ambulatory EMRs today. Instead of doctors writing the note, ChatGPT is summarizing the note and doctors are looking at it and approving it, right? So literally the technology is kind of disrupting the whole workflow. If you think from the payer point of view, the workflow optimization is key more than FHIR, because they need to look at it as a whole. So when we think about from the both regulation and automation perspective, we have all these things coming to a payer, they're really struggling, like which one I should implement first.
And if you go down this list, right, so just to summarize, right, so if you go down this list, if I build it, will they come? That's this question, right? You got a market on the payer and provider side who've just been burned by 10 years of investing in portals that a lot of people don't use, right? If I build it, will they come? If they come, can I do something with that request given my internal payer-specific business rules? If I can do that, will my business systems around enrollment and provider contracting and a bunch of others that I haven't touched for 15 years actually do what I want them to do? And then finally we get to the clinical part of it where we start thinking about automating the clinical review. So I think that's just as a quick summary of that. That's this decision process, and there's lots of different decisions that need to happen here. And a lot of the decision makers who are making these decisions don't know FHIR. They don't know Da Vinci. A lot of them don't even know about the CMS proposed rule yet. So there's an education gap that we also need to bring along with all of the rest of this, of bringing some of the decision makers on the payer and provider side up to speed on what's available from a technology perspective and which of these decisions is going to yield the results that they're looking for.
Yeah. So in summary, I think I want just to bring this perspective, because we're all pretty much into the regulation side, that the Da Vinci and the CMS proposed rule at one point ONC will come. That probably will work in next 2 to 5 years. But if the AI disrupt the industry, and if you are part of this, you need to think at where you are, right? Which bus you are taking. If you are taking totally on this bus, you're really at the mercy of CMS and ONC. And the real question is the provider EMR supporting of a lot of these technologies. You can release CRD apps and all that stuff. I don't think it will scale as much as we think. So be aware of the AI hype cycle. Right? There are a lot of vendors, at least 20 I'm tracking, offering these kind of solutions. And then I think CMS and ONC enforcement is key. I think, as much as we have written all these specs, now they have to make it part of the system. I think that's what is key for us, for our success. I believe even after all this, provider adoption is still hard, because I don't think they'll trust, right? How many things you can auto approve before you gain their trust. The Cambia and Multicare, who implemented the first, and on the other side, CareSource and Cleveland Clinic, it took quite a bit of time to get that trust, having them come to the table and talk about which services you wanted to be part of this, right? So both sides are willing to give up something to gain that trust. So that is very important. The other big problem we are seeing is the payer legacy platforms may not scale, even for FHIR solutions, in my view, because if you were to auto respond with even a pend or auto approve, you need to talk to 4 or 5 systems sometimes. I don't think any of our existing EM systems are capable to have that kind of real-time communication.
Not just the systems, but it's all those business systems. Again, if I have to touch 5 things before I can answer, is an authorization required? And any one of those 5 calls fails, the provider's left with an error. And then if they get left with an error 4 times, 5 times that one user in the same day, they're going to go right back to that fax button that never gives them an error in their EHR.
Algorithms are only as good as the quality of data you feed. So there are a lot of hype on AI. The recent article from Harvard says that even the people who are using the public data sets, they found 3.3% of error rate out of 10 records they've used. So you're potentially thinking that whatever the data you're getting is good enough to train your models, but you have to factor the error rate there as well. I think this part is very proven. The dynamic rules for auto determination based on codes, based on providers, based on payment arrangements and things like that. if you can train your model and see how did I make the decision on my last 100,000 auths, right? Potentially you'll have a good starting point. So that's what we are seeing. You have to start somewhere before you get there. So the other thing,
You go ahead.
yeah, the last thing I would like to mention is that we say that you can look at any technology probably from the point of reducing the review time, not necessarily to auto-determine. Right? If we are taking from 30 minutes to 20 minutes of your review time, still you're getting 10 minutes per review. So that is big ROI for some of the big companies.
And we've had customers use some of this matching clinical data from the EHR into their record. They're touching every single one of them. Still, this is on the provider side, actually. They're touching every single one of these so far, but what amount of time they're spending on touching every single one of these has gone from 9 minutes per to 45 seconds per. You don't have to solve all of the world's problems. We as an industry don't have to solve all of the world's problems right now and get all of this to no touch tomorrow. There's a tremendous amount of lift that we can generate. Still having clinicians looking at this, you've got a clinical eye on it. You don't have to take the high dive off of the 100-foot diving board and hope that you don't belly flop as a payer or as a provider. We can make your people who are doing this today faster until we get to that point, until those AI algorithms are not at a 3.7% error rate. They're more at, say, a 0.1 or 0.01% error rate. We can, as an industry, make people faster and still even have that data that they're generating into the system, even during that 45 seconds per review, have that data help train those models, make them better. So that's one of the opportunities that we see as well.
So with that, I think we have a lot more details with the given time we have. We put together very high level. Happy to share more details on any particular topic, but we'll open up for questions. There's one on the back.
Hi. Do you think that with the Cigna lawsuit for using AI for reducing review time would have a slowdown effect on AI within the healthcare space, people being more cautious, maybe looking closer at state laws and things? Do you think, what are your thoughts on that?
So I think when we think about the AI algorithms, and when we think about AI algorithms being used to do some of this work, there still needs to be structured decision making or structured information as to how that decision was made. I think that's one of the critical pieces that AI has continued to foil the healthcare industry with. I've in a previous life worked at a payer, and we built a deep learning algorithm for automating RX prior auths, and it's still sitting on the shelf, to my knowledge, 8 years later, because no one can tell you exactly how that decision got made. We just had one of our customers go through a Medicare audit, and somebody else have to go through accreditation from NCQA. And if you're using AI to make all of these determinations today and you're happy with the error rate, that's awesome. But if some auditor comes or if accreditation comes around and you need to go back 7 years and say, these are how each one of these decisions got made, and all you have is a huge medical record and a yes or a no, like, you can't, there's not enough registered nurses in the United States to do that, all of those reviews within a 12-month time period that you need to get them done. So AI is great, but if there's no structure around exactly what it's doing, so matching, so when we talk about AI, we talk about matching to one of your medical policies, matching data to one of your medical policies, matching data to an evidence-based guideline, some way, some answer, some actual question. Raj was talking about generating a list of questions. If it's not answering anything besides yes or no, should we pay for this? That might work today, and that actually might not work today, as we talked about with a 3.7% error rate. But even if it does work today, if you need to go back and look at them, you're in big trouble. So I don't know if that answers your specific Cigna-related question, but that's sort of how we look at that. It's like you need some structure around what AI is doing to arrive at that, or you're going to be right where Cigna and what 30 other payers in the last 5 years have been before them.
I think the way I would like to answer that is MCG is very careful in terms of what we recommend to our payers. We only recommend it as a recommendation. Whatever we say, you still do a manual review. And what we do is that when we present these screens to the users, our goal is to confirm our findings because we are very early in this phase. Like, do they agree with our assertions? If they don't agree, why don't they agree? So there is a concept of revised learning, right? The more you see what they're doing based on your recommendation, you learn. And when you reach 98%, 99% precision based on this after a while, you're a little more comfortable checking that box for them. But we are not there yet, right? I completely agree with that process, with the lawsuit, because there are a lot of people jumping to auto determination, and we have to be really careful about that one. Thank you for the question. Very good question.
A related question. This balance between how do we use artificial intelligence to address the fact that we're getting information from multiple sources, we're getting it through different channels. FHIR may be the transport mechanism in a way, but it doesn't enhance the data inherently. It may organize it better. We also have this problem that AI is, especially with the lack of traceability or explainability, AI is going to be applied to data that are in pretty bad shape on both the payer side and the provider side. How are you counseling your provider and your payer clients about the level of digital discipline they need before AI becomes a really useful and explainable technology? And what do they do in the meantime? Because right now, as you pointed out, an algorithm applied to the data that we have today is problematic. You can't audit it, you can't explain it.
So at MCG, the data science team we are looking at an NLP approach where we take a lot of notes from, working with a payer or somebody and then we are very transparent about our process because it's even an education for us. How do we make sure this is not really going out of bounds? So when we show our NLP process of how we tag some of this data to ensure that it is the clinical integrity documentation is something, the CDA is there for a long time. So we take it very seriously. That's why we are very slow in the market on that end. We have released 4 machine learning models in this space. And they're all highly adopted right now, but because we have tested probably 6 months to 1 year with certain market. So our discipline is to just be transparent about how we are doing it, what data we are using it, and where we are successful, we'll show the precision percentage or accuracy percentage. And we are not really selling it too much. I'm just cautioning because it's happening on the other end. A lot of other vendors who are being invested by the venture capitalists. So I don't know what kind of discipline they're doing. Our discipline is being very transparent about how we develop this model, and if they're willing to use it, and let them use it. If not, don't even show them. So.
And the other approach there too is Raj talked a little bit about the traditional rules engines. Leave AI out for a minute. When we walk into a payer, oftentimes we'll say, hey, you should start by writing out some business rules that are just like straight up configurations. And they're like, I don't know if our data is in good enough shape to take advantage of any of those business rules, if this, then that, traditional rules engines that have been around for a long time. That's your first clue. Your second clue is go to the team that enters faxes into your system that come in from providers for prior authorizations. How many pages is their job aid? If it's not many, your processes and your data are probably pretty good. You're not asking that person to do a tremendous amount of cleaning as things come into the system. They don't have a lot of other systems they need to go to look up data. Everything is where it needs to be as they're entering that fax into the system. If that's 100 pages, you're in trouble. There's a lot of things that are in that person who's entering that fax. There's a lot of things that are in their brain that AI is going to be, it's very challenging to train AI to do all the different things that they're doing. So I think I like Raj's answer. It's both things. It's be disciplined in what you're doing, and also use methods that have a traditional, those if-then rules are extremely easy to troubleshoot. If it's not giving you the result you want, those are very explainable. It's the data didn't come in, the if statement didn't fire, and that's a problem. That's a very narrow problem that we have to solve. Maybe there's 1,000 of those little narrow problems, but those are.
But the other side of the coin is that the payers are so burdened by administration cost at this point. I hear from some other payers that we are not allowed to hire any more teams for prior auths. But we are open, our technology firms are like, technology arms are willing to invest to take some risks on these AI-based solutions. So you're at a point like you are not able to scale with people, you're forced to use some of these solutions, and I see people are doing it. So that's how things sometimes is going to scale. But I was not a big believer of AI before. But in the last 6 months, I've changed my opinion because it started working in some cases. And the regulation, the longer it takes, the CMS regulation takes another 5 years, and ONC takes another 5 years to adopt by EMR, I think we are screwed. That's my opinion. I think we have a couple more minutes. Any other questions?
Can you hear me? Hey, you alluded to the aspect of dynamic rule engine.
Yeah.
Can you elaborate a little bit more on that? Like if you've done it, what stage you're at, or what you've done? I have another question.
So yeah, the dynamic rules engine is based on certain data elements you'd use about auth request to auto approve or auto append based on a code, based on gold carding, based on service type, line of business. These are all the rules. If you go to a payer, they will use a rules engine where they go and configure if auth request is this and all that stuff. And so that is very manual. So when I'm talking about dynamic rules engine is that you take one step further and say, you go to your decisions and see what are the typical things you have used to approve. For example, if you're approving for a heart failure for day one based on oxygen saturation rate is greater than 90%, based on 3 readings of it, that is your internal formula to approve day one of a heart patient or a pneumonia case, then you can find that using your supporting data documentation. Then you say that should be the rule that you should create. So your machine can look at all the things you are using to make the decisions and identify. I think these are the 5 things you are constantly looking at to approve it. Make that part of as a rule. Humans can't do it because you have to look at a lot of data and comprehend it.
Piggybacking on that question, so there's this popular Conway's law, right? The organizations kind of tend to do what your communications are, and their architecture patterns become exact replication of that. How are we making sure, as we dwell into AI and these groundbreaking technologies like LLMs and then dynamic rule based and all that, how are we making sure that we're not doing the same thing that we've been doing last 20 years and just replicating it?
At MCG, I personally think it is an existential threat because you have to be on that spot to innovate yourself. Otherwise, you will do the same thing, right? So why Amazon is successful, Uber is successful is that they will go out of business any other year if they sleep. So I think the vendors will be successful in this area because they've seen an opportunity where payers are not willing to spend any more money on humans and reviews, and they're open to take risks. And I've seen every payer investing tons of money in this. So these vendors will come into the payer platform and revamp that, whether you like it or not. Gartner released a great paper last year or year before on how legacy platforms on the payer side stalling the innovation, right? So it is real. All the CA was aware of that. So next 5 years, you will see quite a bit of innovation on that end. With that, thank you very much. Thanks for your time.